Hello and welcome in everyone to this PHA Live webinar. We will be getting started shortly. We'll give everyone a few minutes to join in, but while you are here, we are offering this webinar in English and in Spanish. So if you would like to take a moment to listen in Spanish, you can select that room for interpretation. If you go down to the More button on your screen, you should be able to click that or a globe and select the language of your choice. The instructions are here on the screen in both English and Spanish for you to select the language of your choice. I am mindful of everyone's time, so I would like to get started. So again, thank you for joining us this afternoon for a transplantation roadmap, understanding the role of risk assessment in your PH plan. Again, this is offered in English and Spanish, so please take a moment to select the language of your choice. You can do that by clicking on the globe and then following the instructions on your screen. I'll give everyone about 30 or more seconds to select the language of their choice. Perfect. Just a few notes about programming. We will offer this presentation. We'll have our speakers talk, and then immediately following their presentation, we will have our Q&A. You can use the Q&A button feature on the bottom of your toolbar to submit questions to our speakers and panelists throughout the presentation. And like I said, once they finish, they will be able to answer your questions. We understand that this is a really important time and an important discussion on transplantation, but we do ask that you keep your questions generic in nature. Any specific medical questions, we ask that you consult your healthcare team. And also thank you to our PHA Live sponsor, Johnson & Johnson, as well as Merck. And please note that sponsors do not participate in the development of program content or endorse it. Also, PHA is a membership organization, and we have the opportunity for both family and professional memberships. When you join the Pulmonary Hypertension Association, you'll have access to online medical education, connect with other members, the ability to apply for research grants, and enjoy discounts on event registration for our professional members. And for our family membership, it is free. When you join the Pulmonary Hypertension Association, the world's largest organization focused on raising PH awareness, empowering and supporting patients, connecting with other members through PHA's Peer Mentor program. You are helping us also raise awareness for PH. Join the leading organization working to find a cure for pulmonary hypertension. And now, I'm sorry, I was clicking through the wrong thing. Now I would like to introduce two important members of our Transplantation Task Force. All of your panelists that you will see here today are part of that task force, but we have Drs. Debbie Levine and Dr. Jean Elwing, who are chairs of that task force. Dr. Levine is with Stanford School of Medicine, and Dr. Elwing is with the University of Cincinnati. I will turn it over to Dr. Levine to share a little bit more information and introduce our panelists.
Thank you so much. And if we can go to the next slide. We are very, very lucky. Welcome to everyone. We're so lucky to have two very esteemed cardiologists to talk about pulmonary hypertension and risk stratification. They're both experts in this field. In fact, Dr. Benza is the creator of the Reveal calculator. So Dr. Meghan Griffiths is a pediatric cardiologist who is the director of the Pediatric Pulmonary Hypertension Program at the Heart Center at Children's at University of Texas at Southwestern. So welcome, Dr. Griffith. And after Dr. Griffith has spoken about our kids, we'll talk to Dr. Raymond Benza, who is a professor and chief of cardiology at the Eastern Virginia Medical School and at Centera Health. And I'm looking forward to hearing both wonderful speeches and get questions at the end. So thank you so much. And Dr. Griffith, take it away.
I think Dr. Benza is going to go first.
Yes, I'm going to steal the show from Dr.
Okay,
Griffiths just for a
Dr.
second,
Benza, take it away.
just to kind of introduce the idea about risk stratification and why it's important in someone who is approaching lung transplantation as the ultimate treatment for their pulmonary arterial hypertension. So pulmonary arterial hypertension, as you know, is a very progressive disease. And although we have extremely good therapies now to keep our patients healthy, a number of our patients will still need to move towards lung transplantation as the definitive cure for this disease. And lung transplantation to pulmonary arterial hypertension is really a scale. You really have to weigh the risks of the transplantation versus the risks of continued medical therapy to make a good decision for each patient that is approaching this particular route. So when we think about the scales of medical therapy for transplantation, it's really an exchange of one bag of things to do for another bag of things to do. The continued medical therapy, as you know, has its risks associated with it. Most people who are referred to transplantation are really on multiple medications to try to control their pulmonary hypertension, and they haven't been moving in the right direction. They haven't been lowering their risk profiles. And so continued medical therapy does have a risk of death associated with it if the therapies are no longer pushing our patients in the right direction. In addition, at that form of their disease, the quality of life is often a big factor. These people usually have many symptoms related to their disease and or suffering from many of the side effects of the medications that we use to treat their underlying pulmonary hypertension. So you have to weigh these risks of death and quality of life versus the risks of transplant. Transplant is not mortality free. There is a risk of dying after transplant, particularly in the first year when that risk is the greatest. As you are getting used to the new set of lungs, there are risks of rejection and organ deterioration. Although these are quite low, you always have to keep that in mind. In addition, the quality of life after transplant, although is very, very good, it's not without road bumps. People can have rejection. They can have infections related to the medicines that they're on to maintain their new lungs. And again, side effects from the immunosuppressants that they have that are protecting this new organ against their immune system. So even at this stage of the game, there's a balance in factors that you have to take into consideration when you make this really big decisions. So one of the things that we try to utilize in order to help our patients make the right decision is to try to weigh the risks of dying with continued medication for their PH versus the risk of attrition during that first year of transplantation. And the way we take a look at a patient's risk is by looking at a variety of different factors. Now, these factors are very well known to everyone with pulmonary hypertension because every time you see the doctor, they're assessing their New York Heart Association classification, which basically measures how breathless you are from anywhere from ordinary activities to more moderate levels of exercise. You get that very annoying 6-minute walk test every time you go see the doctor, and periodically you go to the cath lab to get hemodynamics. But when you look at each one of these individual factors, you can see that they're not really good at predicting whether you're going to live or die when you're using them as an individual factor. In fact, many of them are no greater than random chance in predicting your likelihood of surviving with your pulmonary arterial hypertension. And because of this, us in the field have developed a number of prognostic equations or calculators. And what these calculators do is they combine all these factors into one very large equation that can very accurately predict how long you will survive with your current disease. And then we use this disease marker to reverse it against what's the likelihood of you surviving your first year of transplant. Well, in the United States, we make use of two tools in order to stratify your risk. And these are tools that are done both at baseline and almost at every time you see the doctor, they are calculating this risk for you behind the scenes. And these are the two reveal risk calculators that Dr. Levine mentioned earlier that I helped develop almost a decade ago here in the United States. The Reveal 2.0 calculator is really the parent structure that is used around the world to determine what your risk of dying or having an adverse event is with your pulmonary arterial hypertension. And you can see that on the first column, all the risk factors that we take into account when we develop a score for you based on Reveal. What type of pulmonary hypertension you have? Do you have it related to connective tissue disease or liver disease or heritable pulmonary hypertension? How old you are, what your gender is. Have you been in the hospital for the last 6 months? What do your kidneys look like? What does your vital signs look like? Your blood pressure, your heart rate. Again, your functional class. How short of breath are you when you're doing anywhere from normal daily activities to moderate activities? How far you walk on your 6-minute walk test. And then your laboratory evaluations, particularly a very special lab called a natriuretic peptide level. And this is a little hormone that's secreted by your heart when it's under duress. So we can see how much stress your pulmonary hypertension is actually exerting on your heart by getting this little biomarker from your blood. As you know, we do echocardiograms throughout your disease state, and we look at that echocardiogram, and components to it are included in this score. We also look at your lung functions and then the numbers we get from your heart catheterization, how high the pressure is in your lungs, and how high the pressure is in the right side of your heart because of that. And what we do is we calculate a score from each one of these variables, and we come out with a composite score that ranges anywhere from 0 to 21. Someone who has a score from 0 to 6 is considered at very low risk of having an event related to their pulmonary hypertension. In fact, their survival at year is greater than 95%. These people don't need transplant, obviously. If your score is a 7 to 8, you have a more intermediate risk of dying, anywhere from 5 to 10% per year. Now, these are some patients, despite the medicines they're on, we might consider for transplantation if they're on maximally medically treated therapies. And then finally, the group that we really want to identify the most, which puts you at the highest risk of dying from your pulmonary hypertension, is when you have a Reveal score greater than or equal to 9. Many of these people will have an attrition rate greater than 20% of the year, and these are the people that we particularly identify and want to move to lung transplantation, as we'll hear earlier, as kind of a safety net. We can also use an abbreviated form of the Reveal calculator called Reveal Lite 2. And this is a very fast calculator that we can use on the fly. In fact, every time you come to clinic, we can calculate your Reveal Lite 2 score, because you could see it uses a very smaller number of variables, but still is a very robust predictor of your outcome. And just to show you an example of how we use that, so here's the Reveal 2.0 calculator, and we're going to calculate the risk of a patient who has group 1 pulmonary hypertension, is idiopathic pulmonary arterial hypertension. They're functional class 3. They have low blood pressure and a high heart rate. They have been hospitalized in the last 6 months. They have an elevated natriuretic peptide level. They have a pericardial effusion on their echocardiogram. And when we do their score, you can see this person's score comes out to be 14. And when we plot that on our survival curves, you can see that this patient lies on that green line and has a very high risk of dying related to their pulmonary arterial hypertension on their current medications. This is a person that ideally should be looked at for transplantation if they check all the boxes and are healthy enough to undergo this procedure. Indeed, when you look at our guidelines for treatment of pulmonary arterial hypertension, you can see that patients who are deemed high risk, even at their initial evaluation or at the repeat evaluation, are recommended to undergo lung transplantation. So anytime that you hit this high risk marker, lung transplantation is something that we want to consider for you, particularly if you have persistently high intermediate or high risk characteristics based on these calculators. So when we make a decision on your prediction of how long you will live with your disease. In this case, the Reveal calculator curves are on the left-hand side of your screen. We show that this prior person we evaluated was on the green line, having a 40% risk of dying from their pulmonary hypertension if they remained the current state. Well, then we look at their risk of dying with a lung transplantation. And that's when we use the survival curves on the left. And you can see that a particular person, based on their age, what their 1 year survival is in patients who have disease. And in this case, most of our patients will experience a 90% survival after transplant. So if you have a risk of disease in which you only have a 60% chance of surviving and a 90% chance of dying after lung transplant, it's often a very easy decision when you make this because your risk of dying after transplant is much, much lower than it is if you continue on the same course of therapy. So this is basically how we determine who is going to be required for lung transplant and who does not need lung transplant. So the most important thing that we have to offer patients is something what we call a safety net. And as I mentioned, anyone who is deemed high risk from these scoring systems, when you see the physician, we want to offer them the opportunity to be evaluated for lung transplant. And this is not something that you should be scared of. This is an opportunity to provide you with a safety net so that if your medical therapies do not make you a lower risk, we already have your workup done and we can automatically list you for transplantation, and so that you can start enjoying the benefits of having a new set of lungs. And so with that basic explanation, I just want to turn the screen over to Dr. Griffiths, who will talk a little bit more about how we do this same sort of risk stratification in patients who are children suffering from pulmonary arterial hypertension.
Thanks so much, Dr. Benza. Let me just pull this up. And thank you all for having me. So Dr. Benza, of course, is the leader on risk stratification, but is teaching me and helping us advance the field so much here in pediatrics. So I want to talk to you today about why risk matters in your child's pulmonary hypertension and learn some of the tools that we're using to assess this, keeping in mind that this isn't nearly as well delineated as it is for our adult counterparts. And we want to talk about how risk information can guide the treatment decisions and how this is something that changes over time. And most of all, I want to empower all the parents to know about your child's risk, be informed about your child's disease, and feel prepared to ask questions and be a partner with your medical team. So I think you all likely already know this, but pulmonary hypertension, the right side of the heart has one job: get the blood to the lungs to pick up oxygen. And we all know that in pulmonary hypertension, those blood vessels are closed down for many different reasons. And over time, what happens is the right heart starts to get sick under that extra workload and starts to fail. And what does that look like in a kid? Oftentimes shortness of breath, even with just a little bit of activity. Children are much more likely to faint. And the thing you're always going to hear at a visit is, well, how are they doing keeping up with their friends? That is one of our best ways of assessing. Can your kid run around after their siblings? Can they keep up with their friends on the playground? Or do they have to continue to need to stop and rest frequently? So why does risk level matter? Well, so pH, as we know, changes a lot over time. It can get worse, it can get better, especially with kids in the setting of an illness or something like even just the common cold, it can get worse. But when we use a risk assessment, it can give us an objective way to tell you at each different visit, how is your child doing? And say kids at higher risk would benefit from more aggressive treatment. And if we catch them early and treat them more aggressively, we can improve their outcomes long term. And giving us time to identify those kids who are high risk can give you the information to guide a transplant referral earlier. because for kids especially, there's many fewer transplant centers, and the transplant wait time is often a lot longer. So we want to be very, very forward thinking about what the future holds and identify, hey, things aren't going as well. You aren't responding as quickly to therapies as we might like, or your child is not has stalled and isn't improving or is getting worse. It's time to think early about a transplant center. So in pediatric PH, risk means the chance that your child could die from the disease, and usually within a specific time frame, say in the next 1 year or 5 years. So this is the big guideline that came out in 2024 for the pediatric pulmonary hypertension, and it kind of guides doctors on how to think about escalating therapy. And it all is really based on risk. So the first question is, when your child has PH, that your doctor is going to ask is, are they at lower risk or are they at higher risk? And then after they start them on therapy, they should be reassessing their risk regularly and seeing, are they having a good response? Or if they don't have a good enough response, we should start thinking about the next steps, like transplant referral. So how do we check risk in kids? It's a little bit similar, but not quite as systematic as in adults. So we talk about how far can your child walk, that 6-minute walk distance. Are they getting tired easily and not keeping up with their friends? Are they fainting? There's a blood test that your child has probably had called a B-natriuretic peptide or an B-natriuretic peptide, NT-proBNP. This is released by the heart when it's under stress, and a higher BNP is a warning sign. And then your child's going to get an echocardiogram, that ultrasound of the heart, that can tell us how the right side of the heart is doing. And a lot of these measures in children can predict outcomes or can give us an idea about how high risk is. So while in the adults we have the really well established reveal score, in children our guidelines are a little bit older and not quite as organized, but we do have some determinants of risk. So things like fainting is a higher risk, higher blood pressures in the lungs is a higher risk. A shorter 6-minute walk distance, if your child is old enough to do that, is a higher risk. And a very elevated BNP can suggest a child's at higher risk. Following these at every single visit and systematically seeing, is your child getting better? Are they worse or are they the same? Can guide us a little bit more early. So I talked about BNP. This is a great biomarker that your doctor should be checking regularly. It's released by the heart when the heart is working too hard or under pressure. It's a very simple blood draw that can be done in clinic or in the hospital. And the trend, especially in children, is important. And a high BNP at diagnosis or BNP that changes over time tells us that we should be intensifying treatment. And this is from a study where we had 793 children with pulmonary hypertension across multiple centers. And in the patients with a high BNP, a much higher proportion of them ended up either dying or requiring referral for lung transplants. They spent more time in the hospital. That was both at 1 year and at 3 years. And likewise, in that study, we were able to track how kids did over time. And you can see on this graph, at the initial visit, 49% of the kids had a very high BNP. But after 1 year, the majority of those were actually after treatment in a lower risk BNP. On the other hand, some of those patients who are in this lower risk BNP category ended up going to the high risk category. And that's the whole point. So we want to pick up these markers that are telling us that things aren't going as well and pick that up early. So I mentioned that we're not quite as systematic in pediatrics, but we're trying to be. So there's hopefully soon the new Pediatric International Risk Score, and this has been a collaboration across multiple groups. So the U.S. and North America Pediatric Pulmonary Hypertension Network, our colleagues at the Dutch National Network for Pediatric PH, and then our colleagues at a group called RehiPed, which is most of the centers in Spain and some centers in Colombia, who've all worked together to develop this multidimensional score. And it's a machine learning AI model that has 16 non-invasive measurements that predicts risk over the next year. And we consider things that are already measured at your visit, like blood pressure, the oxygen saturation, your child's growth. Are they growing well? Are they growing poorly? Some findings on their echocardiogram, and some of the usual blood tests that they're probably already getting. So the whole goal with this is that there's no extra invasive procedures needed. And when we looked at this a lot across multiple countries, we were actually able to separate kids into who is low, medium, and high risk. So this is from our Pediatric International Risk Score paper, and you can see here this kind of funky looking graph here on the right shows what was the most important variables. But really, it's stuff that you're already doing at your visit. We're getting age, height, weight, calculating BMI. We're checking a blood pressure. We're doing the echocardiogram and getting an EKG, and we're getting those standard lab tests. And when we put all of those together in this machine learning model, we can actually predict outcomes. So this is showing the actual outcomes. So this is over 10 years. The green are the people who were low risk, and you can see over here, they did really well over time. The yellow is the people who are medium risk, and the red is the highest risk. So for each level that they go up, their outcomes, so their risk of death or transplant, were much, much higher. But what we also found when we looked at this over 1 year, this is over 1 year, people's change in risk. So some of these people in the red bars here, these are people whose risk increased over 1 year. But the folks here in these two green bars, these are people whose risk score actually went down over time. And the children who went from either a high or a medium risk and became low risk at 1 year had much, much better long-term outcomes. In fact, 80% of them were transplant-free and still alive, doing well at 10 years. So I'm going to work with Dr. Benza here on this next slide, which shows a combination. This is from his group called FORA, looking at pulmonary hypertension outcomes and how we can show, how we can involve you as patients and families to take a look at risk.
You know, one of the questions that I know that many people had, maybe if you could just stall that 1 second, Megan, was that how does your doctor actually perform these risk stratification? Well, there are tools that we use, as I mentioned, these calculators, and these calculators are available online, as shown in the upper left portion of this panel. We can go right to this website and we can calculate your scores based on this website. We also have a new website called the FORA website, which allows us to calculate your scores, but also keep track of your scores over time. So, for example, this person on the top right panel, you can see how their scores matured over time, and it's actually gotten worse over time. This is a person whom we really want to watch very carefully for transplantation. And this website also allows us to do a lot of other options, like how can we get this patient better? Okay, if I make this person walk further, what will they survive? So we have these what if scenarios here. And then based on these scenarios, this site will also give you treatment recommendations on what exactly you should have. And we're just going to show you a little demo of what FOR allows you can do so you could see the sophistication that a lot of your physicians use in trying to predict these risks.
Patient's risk of mortality from pulmonary arterial hypertension. Clinicians can easily add new patient data manually by selecting Add New Patient and entering the required demographic and medical information. With a single click on the View button, clinicians can instantly access a patient's history and trends from previous visits. The patient dashboard provides a comprehensive overview of historical trends across multiple PAH risk assessment models, enabling clinicians to track changes in patient risk over time. The What If analysis feature enables clinicians to test how a patient's risk would change if one of their lab values were different. This feature allows them to create and save multiple scenarios for visual comparison. The treatment analysis feature provides clinicians with insights into how a patient's treatment plan may change in response to different scenarios, allowing for informed decision-making. Sign up today to unlock data-driven care with Harris Clinic Decisions for Treatments. Optimize treatment decisions and drive better patient outcomes with Aura.
So at your next visit, I think both Dr. Benza and I have questions to ask your doctor. So for both yourself or your child, what is your BNP today? How did it compare to last time? What does this mean for your treatment? Are there other measures? Ask your doctor, are there other measures that I should be looking at today or that you are looking at today? What is my risk category? Is it low? Is it intermediate? Is it high? Has it improved? Is it getting better with therapy? And if I'm at higher risk, or if my child's at higher risk, what other treatment options are available? Are there clinical trials we should know about? And at what point should we be thinking about consultation with a transplant team? And so my takeaway to everyone, I think, today is that risk can be measured. We can use things like BNP, echocardiogram, and our calculated scores like the REVEAL score and the up and coming PERS score to give us reliable, very objective information for how you or your child are doing right now. And that this can change over time. This isn't a stable thing. But with treatment, many patients can get better, and we can objectively measure that with patients moving from a higher to a lower risk. And that always remind parents, and I suppose everyone else, that you are part of your team and you're part of your child's team. So asking about your risk and understanding your risk can help you ask better questions, recognize warning signs for yourself, and hopefully allow you to partner better in care. I think if you want to contact either of us, we're always happy to take questions.
Well, we really appreciate everyone's listening today. And, what we wanted you to take out of this particular presentation is really to try to understand your risk of your disease. And when transplantation is discussed with you, it's really offering you a safety net, an opportunity for you to live a longer life. And we balance this risk of living after transplant with your risk of living with your current disease. And whichever provides you the longest length of life is usually the one that we will offer to you based on these very sophisticated risk assessments that we do in clinic. So I hope everyone understood how we do that, how we try to make these decisions on who should go to transplantation and who should not. And we'd be happy to answer any questions you may have at this time.
Thank you so much, Dr. Griffith and Dr. Benza, and just to the audience, knowing that you have the world's experts and even the creation of a risk assessment here on this webinar. So thank you so much for those wonderful explanations, presentations. I always learn from Dr. Benza, and this is not this is just the same for this session. I think we have some questions, and again, we can see with we can name some of the questions, and Dr. Benza, Dr. Griffith from the pediatric side. We can maybe start with one of the first questions is risk assessment in PH patients with multiple comorbid conditions or other diseases that play into how does that affect the functional class?
That's really a great question and very insightful one. We actually, in some of our more contemporary calculators, we include these comorbid conditions as risk conditions. For example, you saw in the REVEAL calculator how we included patients' kidney function. So someone who has chronic kidney disease has a much higher risk of dying from their pulmonary hypertension than someone without kidney disease. And so these comorbidities, which increase the risk of dying with PH, play into that score and allow us to consider the risk of someone living with these comorbidities and their PH versus their risk of living after transplantation. Now, obviously, those comorbidities play a major role in your survival after transplant. And like pulmonary hypertension, we have calculators to determine your survival after transplant, in which these comorbidities play an important role. So again, it's a balancing of that scale of risks between continued medication and risks of transplantation that we're always looking at to make the right decision for you.
Guys, I have to tell you, this is very good. And as a provider, it was really, really helpful, but as a patient, extremely helpful to how to integrate yourself into this risk assessment and really be able to engage with your provider, understanding that. So we do have a question about frequency, and I'm going to ask Megan this. How often do you risk assess? And would there be a time where you would do additional risk assessment or maybe skip because of an illness or something of that sort? So tell us about that.
I think every visit. So I think you can look at this as a trend over time and see and reassess and recalculate at every visit. And if there is a change, you can assess, well, why was there change? If there was an acute illness, that's a very common thing in children. For example, that a child gets the common cold and their pulmonary hypertension risk increases, but that's also an objective measure that that child is at quite high risk because they got a common cold and their pH risk increased or even put them in the hospital. So I think every visit we should be checking these things. And as we mentioned, everything on the reveal score and everything on the PERS score and pediatric risk assessment is part of our very standard clinic stuff. You know, you're always getting your blood test, you're always getting your echocardiogram, and you're always doing your 6-minute walk test. There may be more infrequent ones, like say every 1 to 2 years, where you do the escalated stuff, like a right heart cath or a cardiopulmonary exercise test or an MRI. But I think for the basic stuff, we should be looking at it at every single visit because every visit is an opportunity for us to optimize.
Yeah, I agree
No,
with
but
that, Meg. And I risk assess every time I see a patient in clinic. Every time I see someone, they'll get a Reveal Light 2 score. And I plot the trajectory of that score over time. And these very, very acutely can depict changes in your outcome over the long term, so that if your trajectory is moving in the wrong direction based on these scores, we can actually make that score even finer by adding additional tests to it, like a right heart catheterization or a cardiopulmonary exercise test that Megan mentioned, to really give you a very detailed and highly discriminatory score that will tell you exactly where you are in your disease trajectory. So every opportunity to do risk assessment is a great opportunity. And really, when you go in to see your physician, you should be asking them, Doc, what's my score? So you keep yourself informed on where you are on that trajectory and be your own best proponent.
That's such a really good assessment. And I think along with the risk assessment tools, there's another great question for both of you. Are there any other risk assessment tools in development in addition to FORA?
So FORA and PEERS, which are the two equations and algorithms that we just discussed, are the most contemporary scoring systems that we have. Um, uh, FORA will almost supplant Reveal, I think, in the next few years as the main risk stratification tool that we use, because its ability to discriminate who will live or who will die is highest among all the contemporary scores that we have, despite those developed in Europe or those developed in the United States. And we're always adding to FORA. So as new variables come into the literature, we'll assess them into incorporation to the score so that we continue to have a score that really reflects the way we take care of patients in a modern era.
I think for children, we're still very much in the infancy of developing systematic risk assessment. Um, and so there's a lot of work going into this. The PERS score covers both children 3 months to 21 years, and includes children with lung disease as well as group 1 more typical PAH. But there's still, I think, a lot of work to be done, and people working on risk scores for kids with, say, congenital heart disease, which is a major problem for kids, and trying to refine things for kids with, say, developmental lung disease who were born premature, kids with certain syndromes. So I think there's a lot in the pediatric community working on that, and as that work comes out, we'll also start trying to incorporate that into things like PERS.
It's exciting because we have a lot of new medications, and if we can really hone in on who needs more or changes, it's so helpful. So I'm trying to put myself in a patient's shoes or a parent's shoes and thinking risk might be scary, right? Like you might be not wanting to know your risk. So how do you deal with those conversations where you know you have a patient who's high risk and you want to try to explain to them why knowing about this is so important, and how do you convey that without being so frightening?
Well, it is a frightening thing, but this is a true testament of the relationship between a physician and their patient, the ability to talk about these very sensitive issues in a way that is understandable and without fear. Um, we have lots of things to combat this disease, and your physician is always thinking, based on your risk assessment, what's the next medicine we should use? Is there a combination that we could use? Well, if you're on everything you possibly can, let me explain the risks of transplant to you versus the risks of just staying on your medications. Transplantation has markedly evolved over the 3 decades that I've been doing it. Our survival has markedly improved with new techniques and novel immunosuppressant drugs, so that many of our lung transplant patients are living greater than 10 years now with a transplanted organ. And so this type of knowledge is something that we need to impart to you to reduce your level of fear, to make you comfortable making these decisions together as a team. And I think it's always important to remember that your doctor always has your back. This is what we do, and this is what we come to work for every day. This is what floats our boat, is to make sure that we protect you and that we give you these safety nets. And that's one of the things that transplantation should be viewed as a safety net. Just because you're on a transplant list does not mean you're going to get transplanted. You may get better on the transplant list with new therapies that are coming down. Your risk may drop because a new drug comes down, in which you can just easily come off the list and still be the protected part of having that name on a waiting list if your condition were to get worse again. And just
I
remember that the list is a very dynamic and living structure.
And I completely agree with Dr. Benza. I think so much of this is about the relationship between you and your doctor and your ability to speak with them or speak with them, your child's doctor. Risk is scary, but I think it's because pulmonary hypertension is scary. I mean, this is a severe disease, and for many kids, they present with very severe presentations, fainting, or a major event. Um, and so I think we have to be able to speak honestly and openly about it. Um, and remember that we're all going for the same team, which is the best possible outcome and the best possible long-term outcome. In pediatrics, even more, I try and think about not just the 1 year outcome, but the even longer term outcome, and also what low risk really means. It doesn't just mean freedom from a bad event or freedom from transplant. Getting better for a kid from pulmonary hypertension also means, oh, I got to participate in gym class, or I got to go to prom, I got to go to summer camp. So I think it is really worthwhile, even though it is a difficult conversation. I see a question in the chat about if they're younger, do I have these conversations with just the parents? Absolutely. I think my clinic and probably most of my pediatric colleagues' clinics have setups to help manage that. So we have a child life team. My nurses are obviously phenomenal, and will either come and take a kid for their 6-minute walk test or say, hey, One of the hospital puppies, we're pediatrics, we do have hospital puppies, is visiting the waiting room. Do you want to go over there, so that the parents and I can have the more difficult conversation and then find a more appropriate way and time to discuss it with the child?
I think these are, I think some of the things you guys have really mentioned in this last section have been really important. And when it comes to, and there's a couple questions that we have on this is, as you improve on medications, where do you stand with both therapy and even the consideration of transplant? And I think the idea that this is this disease, as others are in our field, has kind of an unpredictable trajectory. Everyone doesn't slowly go down or go down very quickly. There may be ups and downs. And so I think the way that you have to consider this disease is an unpredictable progression, and patients may be very, very flat in terms of their progression, and maybe at times they'll be more progressive. So having a discussion early about even some of the more invasive therapies and transplant and others that may not be there at the window now, kind of gives the patient's family, and or the children, kind of a way to get used to the idea or hear about it, understand it, ask questions. And I think that's why sometimes even when you're not at the point of needing an invasive therapy, talking about it as one of the options coming up, it may be easier to hear about it now when you're feeling pretty good than when things aren't going well later on. And you'll at least have heard about IV prostacyclins. You'll have at least heard and understood what transplantation is. And a discussion is not, an education is not always a referral, but it is something that you can start with and kind of have a baseline knowledge of. One question that comes up with this is if my risk assessment goes down, do I decrease my medications?
Well, that's a great point. I could tell you in my own practice, I rarely will do that because we know that pulmonary hypertension, as Debbie just said, is a progressive disease. And so if we make you low risk with the medicines, that's what's keeping the disease at bay. Now, there are times where medicines can be switched. So a medicine that might be a lot more invasive can be switched perhaps to a medicine that's a little bit less invasive. And as long as it keeps your risk as flat and low as possible, that's a decrease in therapy, in my opinion. But I think it's very rare that we take patients off of medicines when they achieve low risk.
Yeah, I agree with that. I think I talk with families about, especially for certain types like idiopathic or heritable pulmonary hypertension, that this is a disease that's with us for life. And our goal is to stay a couple steps ahead of it. And if the medication is keeping us there and that the child is otherwise having a good life, is able to do all the things they want to do, then then the medication is giving us the benefit and facilitating all of those things. There are certain times when if they're very low risk and also say something like sub-Q Remodulin, or sub-Q treprostinil is causing a problem, then maybe we consider switching to a less invasive medication. And I think that's a conversation that somebody has with their doctor or with their child's doctor to weigh up those risks and benefits. But for the most part, I agree with Dr. Benza. If the medication is what got you to low risk, the medication is keeping you at low risk and facilitating both your quantity and length of life.
Yeah, I think you should think of it as keeping you low risk is going to keep you all the time you need for the cure to come out for pulmonary hypertension. So there's no need to make you feeling worse by withdrawing your medication. Keeping you at that low
Yeah,
risk is going to allow you the time that we need to find that cure. And
yeah.
that's when some of these medicines might be replaced if we develop a new super medication that can really drive this disease state to a very quiet and quiescent state.
And maybe not even a cure, but even a better medication than one that we know of now. But I think that's in the future, and I agree 100% of keeping stable patients on stable regimens if they're doing well.
So I heard some really important things. Like Debbie mentioned that to talk about transplant, let's not have this be a surprise when a person is really in trouble. So I think that's really important. But also heard that we send people to transplant when they're high risk. So again, putting the patient shoes on, thinking, do I have to be in high risk for a long time till you let me go for a transplant evaluation? Or how long do you wait? Do you try some medicines or do you send me right away? And if you send me right away, will that be a wasted visit for the team that I'm going to? How do I rationalize all of that?
I
Either
think
one.
it's never a wrong choice to send a high-risk patient, whether it's at time of diagnosis or further on in therapy, to get an upfront evaluation by a lung transplant physician. That way your name is known. Some of the evaluation can be completed and just stored, where you can pull it out when you need it. And that's what the whole concept of the safety net is. We want to supply a net for you if you were to fall, and having the information there to the transplant doctors, having the evaluation in your back pocket can secure you a rapid place on the list if the medicines don't put you in the right place. And a lot of times they will. I remember what we said, the transplant list is a living list. People come on and off the list all the time because people can improve while they're on the list, particularly if a new medication is started and it hasn't had the time yet to really drive you back. Well, let's watch you on the list while that medicine's working to give you the ultimate safety net. That's my philosophy. And I think many of the philosophies that came out of the New World Symposium on Pulmonary Hypertension support that safety net concept. And Debbie, you were one of the originators of that safety net idea from the World Symposium, and I just love it. And I use that analogy all the time.
It is a really good I think it is a really good analogy, both in terms of being a real analogy and also knowing that that patients aren't always going to do their trajectory is not always going to be what we think. And even if a patient is doing well now, again, we know one infection, one time that someone goes the wrong way very quickly, um, there's no question it's easier to be known by a transplant center. We don't care if a patient comes in and we say, you're doing well. We'll see you in 1 year. We'll see you in 6 months. We'll say hi. Um, there's no transplant center in the country, in the world, that would be unhappy about seeing a patient early just to kind of see where there is. And I think one of Ray's slides was really important, that it says sometimes there's barriers to transplant that aren't irreversible. There's some reversible barriers. Patient may be too low in weight or too high in weight. A patient may have a lot of problems with strength and conditioning that need to be improved before they get to the list. These things can be worked on. Maybe a patient is using a substance, like maybe they're on something that shouldn't be used after transplant, weaning these things off. I mean, there's many reversible changes that may have to occur before a transplant. Why not get those done early? So if it does come to the point where you need one and you need to be listed, then you're ready. And no center would ever argue at that point.
I think also
No,
to
that's a
your,
really good point.
yeah,
So sorry, Megan, I interrupted
I
you.
was going to say to your point earlier about talking about risk is scary, the disease is very scary, but when you're approached with something like that, it's often good to have the full options and the full picture of what this could mean. So if you present and you're high risk, you're just starting medications, we don't know if you're going to respond. I think that's also a really good time to talk about transplants and have a sit down conversation and say, this is, there's a question here about, do you share scores with your patients? Yes. I'm very honest with people about what their risk is. But then having that conversation early up front about transplant is a possible outcome in this case, or a transplant is something that we would send you to, and let people find out early.
So are there things, Megan and Ray, that you do with your patients when you see them? Because in the back of your mind, you have, like, I'm not sure if this person is getting better as quickly as I'd like, and I might need to really refer them for transplant in the next 3 to 6 months, are there things you start working on, like diet, exercise, social support, anything like that, or do you wait?
No, I think that's another great point. Gene, in my very first visit with people, I actually talk about transplantation as a potential future option for them. And that point of the conversation, I always turn to their caregiver, who's to their right or to their left, or to their parents, and say, you're going to be the one that's going to help this person get through that process when and if it does occur. And it's the same thing, getting people through the tough medications and the side effects that we use to treat pulmonary hypertension. It's really a team effort. And the caregivers are a really important part of that team effort. So having that conversation up front, I think is very important. One of the things I often do in my clinic is, people always ask me what their score is, but I'm often showing them where they sit on those survival curves so they have an idea of what the score actually means to them. And their goal is to be a green light. I tell them, green light is low risk, yellow light is intermediate risk, and red light is high risk. So think of it like a traffic light. You always want to be on the green. And it's information that your physician should supply for you all the time. It's so easy to say, "Hey doc, am I in the green zone?" And if you are, you could walk out of that room very happy. But if you're continue in the yellow or the red zone, these are where you need to have serious talks about your physician about how they're going to modify your therapy, what you need to do to get you into that green zone. That should always be first and foremost. And diet and exercise is an important part of that. You don't start that at the end. You start that right up front in that first visit, because exercise almost works as good as some of the medicines we are to make you walk longer. So it's really, really important to remain active when you have pulmonary hypertension and make sure you're eating the right foods to keep your heart healthy, to keep you free of extra fluid. So you got to watch that salt too. I know it's a really downer not to be able to use certain things that you want in your food or drink all the fluid that you want, but these are sacrifices that we have to make to put you in that green zone.
That that
Second.
one thing that I love that you brought up, Ray, that is so important. I think maybe even more important than medications after transplant or even before is your caregiver. And I think that it is, like you said, I loved a team effort. There's no one that can do this on their own. And having a patient's family, a patient's friend, their caregiver, taking them from beginning all the way through this journey is so important. And we really relish our caregivers. I know that we're coming to the end, and I just wanted to ask Dr. Elwing and Dr. Griffith and Dr. Benza for any last messages that you want people to take home from this great talk.
Well, I think people should always ask what their risks are, what zone they're in, to make themselves have the right conversations with their physicians. Walk out of your office every single time with that information, so you remain very well informed. And remember, you're your best proponent, so be a good one. There are some questions that were online that we didn't get the answer, unfortunately. A lot of the risk stratification tools that we talked about were really geared for people who have WHO group 1 pulmonary hypertension or pulmonary arterial hypertension. But those who suffer from pulmonary hypertension related to underlying lung disease like emphysema or chronic thromboembolic disease, our risk stratification tools can be applicable in those situations too, but they're not designed for those particular states. So there are other reasons and other ways that we risk stratify you to make the right decision on whether you should go to transplant also.
Yeah, I think Dr. Benza's point about being an advocate, I always tell parents you are the primary part of the team. There is no question that is a wrong question. Get informed. I try and give patients and parents, here's the PHA information, here's the PPH net information. If you want to talk to another parent who's had a kid that's gone through this, so you can find out what things you really need to think about. Being an informed parent and a great advocate for your child is always the right thing to do.
Mine is simple. Risk knowledge is power.
Yep.
Mine is even simpler. Early discussion is best.
Yes, got it.
But I really want to thank Doctors Elwing, Doctors Griffith and Benza. This was an amazing discussion, and thank you so much to PHA and Angela for getting us through this. Thank you.
Thank you so much. Thank you all for sharing this wonderful information. I feel like there was a lot more we can discuss, but we will be continuing this transplantation roadmap in a series over the next year. So stay tuned for more details. I believe the next part of the series will talk about referral in that process. So stay tuned for that in August. Again, thank you to our panelists for sharing this important information. The recording will be available later. We will notify you of that. And then also, again, thank you to our sponsors, Johnson & Johnson and Merck, for their support of our PHA Live programming. Sponsors do not endorse or contribute to the content of the webinar. So thank you all again. Y'all have a great rest of your day, and we'll hope to see you on the next webinar. Bye-bye.